We'll continue from where we left off in the history taking of a child. We are covered on that day, presenting complaint, history of presenting illness, past history, antenatal, natal and postnatal history. And in this video, we'll be completing the history with the rest of the major points in the history. In this, many of these headings are major topics, core topics in pediatrics. The developmental history, nutrition history, immunization history, all these are major topics. We'll be taking that in detail. And socio-economic history and family history. We'll be just touching upon so that we'll be completing the history. In continuation with the postnatal, antenatal, natal and postnatal, development history is in continuation actually. We need to ask at what age different milestones this baby achieved. We take the development history considering the 4 domains of development: gross motor development, fine motor development, language, social. These 4 domains you need to take because there can be a developmental delay in a particular domain only. There are 2 patterns of the delay. There can be a delayed achievement in all the 4 domains. We will call either any 2 domain or more than that is delayed. We will call it as a global development delay. If it is an isolated delay in one of these domain only, call it as an isolated delay. There are examples of all these patterns. Suppose a child is lagging behind only in gross motor, that is head control, sitting, turning over, creeping, crawling, then pull to sit. All those things are called gross motor. That is delay. But his social, language, intelligence, everything is perfectly normal. So an isolated gross motor delay. So there is a group of disorders which you need to consider if that is a pattern of development. So what will you consider in that context? So gross motor needs power. Anything which is affecting his gross power, this particular domain will be maximum affected. Imagine a situation of your muscle power less in a case of neurological disorder with the peripheral motor unit disorders. So myopathies, muscular dystrophies, anterior horn cell disorder, peripheral nerve disorder, radical disorder, all these motor unit disorders are neurological disorders where you get gross motor delay only. With the minor finger power, he'll be able to execute many of the talents by eyes and fingers. So his fine motor may be almost normal. His intelligence is normal, his vocabulary, his language, his social relations, everything will be perfect. So neurological disorders is one group. There are many other common disorders which also lead to an isolated gross motor delay. One of the commonest one is the malnutrition itself. A nutritional problem predominantly affect the gross motor and the power is more important. Then there are not many systemic disorders. Suppose a child is having a congenital heart disease failure, repeat hospitalizations, his gross motor will be delayed compared to his peers. Respiratory bronchiectasis with frequent respiratory infections, hemolytic anemias, many other chronic systemic illnesses are examples where isolated chronic gross motor delay is there. Take in another situation where his performance in the gross motor, fine motor and social also is perfect. His relation with the peers, parents, everybody is perfect, but language is delayed. So what is the condition which you consider? Hearing is the problem. So it's an isolated language, it always assess the hearing. There is another interesting scenario which is coming often nowadays more and more aware we are, is autistic disorder. Autism spectrum disorders where the fields, predominantly two fields are affected. One is a language delay, the other is a social relations. So that's another situation. So what about intellectual disabilities? The patient's performance, intelligence, there is no need for his gross motor, fine motor will be delayed, but the maybe a little bit of other social performance and language part may be behind, because of intelligence is more important for that. So based on these findings in the development history and followed by the development assessment, we'll be categorizing, you will be telling it in a quantitative manner. Just like your intelligence, you call it as intelligence quotient IQ. This is a developmental quotient. What is expected is normal is 100%, and what extent he is performing. Example, a 2-year-old child is performing for a 10-month-old child. So you take the 2 years, 24 months. So 10 divided by 24, make it as a percentage. So DQ, isolated field, also you can say DQ in that field is 60%, the other fields are normal. So development quotient is one concept. So the development, when taking history, there can be a delay in selected fields or domains, and you need to know to what extent it is delayed. There are two things: which are the fields delayed. Second thing is to what extent each field is delayed compared to the other peers. Then based on that, you represent it as a DQ, developmental quotient. So this is not assessed based on the history only. It's at the end of your history and the assessment. So what do you mean by developmental history and developmental assessment? Are they the same? No. Developmental assessment is done by you as a part of the examination. Actually, developmental history is part of the history. Developmental assessment is part of the examination. While you do the baby examination, it is one major part. You need to comment about this developmental achievement in different domains. So, if you can assess the child and tell about his developmental milestones, how much is there a delay, to what extent delay by assessment around, why waste your time on the history? Why should you take the history? If by examination also you can do the same thing, you can give an opinion like that. Here is the explanation. This may not be needed, developmental history may not be needed if on assessment he is performing with as his peers, there is no delay. But there is a situation where you assess the development and you feel his development is 50%. His performance in a particular field is 50% at a particular point. Maybe at 3 years you are assessing, and in gross motor he should be running, walking, going upstairs, and all those things. In the gross motor he should be drawing a circle and a speech, many things about the understanding. And the assessment shows that he is performing for a 1.5-year-old child, and the assessment is 50% is the developmental quotient. That situation, the development assessment alone is not enough. You need to go back to the developmental history. So why should you take the developmental history? In what way that help? So just imagine, this is the explanation. This is a graph showing the normal development of a child as age advances, age in years advances. It is how it forms. A child who is delayed from the beginning, he achieves the head control by 1 year. He achieved the sitting by 1.5 years. It stands at 2 years. It started walking at 2 years. Like that, at 3 years, he started walking, pulling the toys laterally. whatever is gross motor is expected for a 1.5-year child, but he is, mind you, 3 years. So that is a little late in everything, and he have reached 50% of the 3 years. He is performing for a 1.5-year-old child. This is one situation. This is the true delay. This is another situation where he was performing much better parallel to the normal child up to maybe 2 years and 2 months. So he was perfectly normal, comparable to a sibling of his age. But what happened? Gradually his development became static, and few of the milestones which he achieved, which was much better, he loses the milestones. And one by one he was running, the running lost, he was standing, and he was not able to stand, like that regression of the milestones. That is regression of the milestones. So one is a delay, one is a regression. So at one point of time, it is just like a still photograph you are taking and commenting. Unless you have a video of these previous situations, just by looking at the static one still photo, you will know only that there is a delay, is performing 50%. How he reached this situation, whether it was normal and regressed to the situation, or was it a delay starting from the beginning, you can't say. That is the relevance of the development history. What is the relevance of this thing for a clinician? There are two types of disorders, which lead to different type of pattern. One is a static disorder. You call it as a static disorder. The other one you call it as a progressive disorder. So what do you mean by progressive disorder? What do you mean by static disorder? We discussed about the problems which can happen to a normal developing baby. There are two major groups. Seed is abnormal or the soil is abnormal. So early period, that can lead to problems. So seed is abnormal. This seed has got a potential. So the expression of the seed can be a little deviant from the normal. That's explanation as examples of all the genetic disorders. So they won't develop the potential of our normal people. They may have a potential which is meant by that seed. So Down syndrome child will have a delay in all the milestones. His ultimate final outcome of the IQ will be much less. So that's because of the attribute of the seed. Then another situation, something happens to the baby in a very early phase of his development which injures the brain. That may be happening in the first trimester during the organogenesis. Maybe at later also up to the age when the development of brain is completed up to 2 years. At one point of time there is a injury to the fetus. The first trimester can be any of the teratogens, and later at the time of delivery, uterine insufficiency, baby didn't cry, hypoxic ischemic damage to the brain, neonatal period bilirubin, IC bleed, infections, many other things. But one thing is, the injury is only once. So to what extent this damage the brain decide the final outcome? There can be a situation where no development at all, the entire brain is burned out. It can be very mild situation. This injury just touched upon here and there a little bit. And what happens? There's always in the nature, new roots comes and cover. New sprouts and roots will completely clear the problem, and you may not have any problem at all. All depends. Can be some damage in the areas which are a little more important. There can be a delay, but there won't be loss of any milestones which is achieved. So compensation by new roots and sprouts, and that is made up a little late, but he's not losing any of the milestones. That is a classical examples of the static disorder. Examples are genetic disorders of the genes and syndromes, and injuries antenatally teratogens or perinatal asphyxia or neonatal injury or later SIDS or any other problems, asphyxia, drowning, all those sort of injuries. And take the other group as it's a progressive disorder. So what is progressive? The injury is progressive. Many of the disorders also is having a genetic basis. All of us, the brain and the other parts develop over time. Lot of metabolic programs are happening. When some of these enzymes or transport proteins or the receptors, they are all proteins. They are defective. What will happen? Imagine a metabolic pathway where an enzyme is defective. The biochemical agents before the enzyme will get accumulated. The biochemical agents which are distal to its deficient. So, gradual accumulation of an unwanted thing because this enzyme is defective, or there is a defect of deficiency of the end product which is needed. So either of this thing or a combination can damage the brain, and what will happen? This keeps on increasing. The accumulation increases, the deficiency progresses. So it's not a one-time injury to the brain. The injury keeps on progressing. Of course, the manifestation also. So you need to consider one thing. There's a normal potential of the brain and the body. The blooming happens as age advances. At the same time, this biochemical problem is gradually building up. So they are fighting each other. Maybe in the initial months and weeks, normalcy dominates. That's why you are getting a normal development initial period, and the other fellow keeps on increasing and they are level. And one moment of time the injuring element takes over, dominates. And what will happen? That point onwards, the drop starts. He goes down in the achieved milestones. So that's a classical examples of this regression. There are many neuroregressive disorders. There are peripheral disorders, there are central disorders, many biochemical disorders which we learn. In the lipid storage disorders you heard, there can be many other these things, mucopolysaccharides, lysosomal disorders, peroxisomal disorders, and it can be peripheral muscle disorders, can be the peripheral nerve can be disorder. So these are all leading to a progressive disorder which lead to regression in the development. So what did we discuss about the development? We need to know more about the development milestones by going to in detail. So how to utilize the developmental milestone? What is the relevance of the history? Asking the mother at what age he developed this milestone, that milestone. That part also is equally important. And maybe in the examination you do the development assessment, you put these things together. If there is a delay, you need to understand the relevance of this development history. Now comes the nutritional history. Again, that's a major topic. Nutritional history. What is the first nutrition to be? It's a breastfeeding. The moment you are born up to 6 months, exclusive breastfeeding. So exclusive breastfeeding means nothing other than breastfeeding. There's no need for additional water. There is no need for any vitamins. Why vitamins? This practice is to give vitamins to all newborn babies. There is no need, absolutely there is no need for any vitamin drops in a term baby with adequate weight without any problems. That's exclusive breastfeeding. Your doctor may advise you to take vitamins or other things only if there is another indication, maybe low birth weight baby, some other problems. You may need to supplement some of the vitamins, calcium and all. But in a term baby with adequate weight, encourage breastfeeding, and that is the only feeding it should be given, advised up to 6 months. No water, no other milks, animal milk, and the excuse of taking a bottle while I am going for a travel should be discouraged. If the baby cannot be fed, don't go for it, because travel is not a need for the baby. It's his right to get the breastfeed up to 2 years, inclusive breastfeeding up to 6 months. So a lot more details about the feeding problems and all you need to go through. And about 6 months, complementary feeding. That again, major topic. So what is the difference of a complementary feeding and previously called it as weaning? What is weaning? Take away something is called weaning. You're taking away. Previously, taking away breastfeeding. That's a problem. You're not taking away the breastfeeding, you're continuing the breastfeeding. You're just adding semi-solid. The semi-solid attributes of semi-solid, it should be in the right time, in the right method and the right item. If anything goes wrong, you are likely to fall in the pit of malnutrition. So, the right time, right method and the right items. So, we learn more about the complementary feed introduction in the late session. And suppose it's a 3-year-old child, you need to ask about how long was this breastfeeding was given, when was the complementary feed had, and what is he getting now immediately before the illness. So you need to ask at what time he wakes up and what all things are given item by item till he sleeps. Is there an early morning feed, late night feed? Everything you need to write in a case sheet, and you need to calculate what is the nutrient value in the form of a calorie, in the form of a protein, the micronutrient, vitamins, fibers, the minerals, everything. So balanced diet concept you will know. And you need to calculate at the end, is there a deficit? What is the required amount of calorie and protein? How much is getting? What is the deficit in each of these? Calorie deficit, protein deficient, and is there a chance of a micronutrient deficient? Because based on this only you are going to plan the right diet for him. Maybe he's having a general examination, finding of a particular deficiency or any problem, maybe obesity also, overweight also. So this appropriate dietary history will give all these things. And maybe a little bit more you need to ask during this nutrition tree, a lot of national programs, whether he is getting the nutrition program. You must have heard about vitamin A prophylaxis program. You might have heard about the iron NIPI, National Iron Plus program, vitamin A program, iron program, iodine deficiency disorders, and you might have heard of adolescents weekly iron folic acid. These are all national programs whether this child is getting. Another thing, whether he is getting the benefit of the ICDS program, because these are needed when you are planning the management if there is a deficiency. And one more very important point, whether is deworming was given and what is his lifestyle, because nutrition, anemia and all, the lifestyle, the open defecation, walking without chapels, all these are important. This indirectly related with the nutrition, that's why. Immunization history. Previously, it is relevant only for a child. Now, when we talk about adult also, there are many vaccines are being given to the adults also. But in this situation, pediatric age group immunization is so important. You need to know the national immunization schedule. And there is one more schedule, Indian Academy of Pediatrics, with another schedule with the newer optional vaccines are also included in that IAP schedule. You need to know both the schedules, ideal, but at least universal immunization program schedule we need to know. We will come with another video with that. And from the newborn period up to the adolescent 16 years, and included is the pregnancy also in the national schedule. You need to ask about the schedule, whether he got each of the vaccines in the right time. Was any vaccine missing? Because based on that you have to plan to give the remaining vaccines. Next is the family history. It is just like any other adult family history. we need to go in depth about the family history, we need to construct a pedigree chart. So we will be discussing about the family history in another video, and maybe relevant in two ways. One thing is for the socio-economic part of the family history, because the number of members in the family and their financial incomes and expenditure, so what is their social status and the education status of the parents are maybe needed in selected cases of the child, and overcrowding, their living conditions, because there can be a illness which has got a bearing on the overcrowding, passive smoking in the family, and family environment, about the sanitation, the water supply, pets, the lot of things. That is one part of the socio-economic history, and about the family members' habits are important. And the another part of the family history is for the genetic disorders, inherited disorders. So there are two types of family history. One, I said, just because of proximity, a member unrelated also may be staying in the family, in-laws, they can give an illness to them by proximity. That is one type. Another is genetic disorder, where they might not have met individually between them. One member is staying here in this state, another member in another state, but the illness they are having has got a relevance here. So blood relatives. So when you consider the family history and constructing the pedigree chart, this aspect of the family history we are giving stress on. The blood relatives, there you need to take in detail about the three previous generations, wherever they are. They may be in another country, another state, and it may be a little deviant type of presentation. So that is the second part of the family history, blood relatives, and that is a true genetic. This is family history, but due to a little bit of social aspect is involved in within family. So in-laws may be having an infectious disease like tuberculosis. Socio-economic history, just I covered a little bit in that family history, but actually lot more details may be needed in selected situations about a number of family members, the educational status, the overcrowding, housing, pets, water, other problems in the nearby situations. Everything is needed. In depth of this socio-economic history may be needed in cases of malnutrition and all. The contact with a communicable disease, and it need to get an idea about the society, how much they are getting the benefit from the programs, the relation with the ICDS, the patient is getting the government program benefit and all. All these things are needed in the socio-economic history. So in a nutshell, we completed this thing. So we are not covering the personal history. This is not part of the pediatric history. Thank you.